Hi folks, it's me, Ali, coming to you from my hotel room here in Chicago. I'm attending the Chicago Midwinter meeting again this year. I had to leave Boston in the middle of winter, so-called winter. We had a little bit of an Indian summer, which was actually a beautiful time in Boston. We had 72-degree weather in February, unheard of by Boston standards, and had to come here to Chicago for the Midwinter meeting, what was, again, still pretty cold. But I'm here, and that's a good thing. And reminds me of last year where I did a little tutorial here from my room. The question that comes up quite a bit on our website, and that's the question of how can we reduce post-operative pain in our patients following endodontic therapy. And I think that's a very good point that applies to all of us, including no matter what instrumentation system that we use, even hand filing, post-operative pain, the incidence of post-op flare-ups, or even mild to moderate discomfort is something that can be maybe not completely eliminated, but it could be reduced dramatically if we understand the concepts behind post-operative pain. And what I wanted to do in this little video is to go down to the board and explain to you guys some of the mechanisms for post-operative pain and then some potential ways of reducing it. All right, so let's take a quick look and see how we can explain some of the mechanism for post-operative pain. Whenever you have a tooth, let's just kind of draw a theoretical, difficult, curved root here. In fact, it doesn't have to be curved. It could be any type of a configuration. What you have is you have a periapical area, which will, depending on the preoperative diagnosis of the tooth, is going to have anywhere from 0 pain to a level of pain for the patient that could be scaled, up to 10. So patients come to us with a certain level of preoperative pain based on the condition of this area at the apex. Now, this could be inflamed or infected, secondary to the content of the bacteria inside the tooth following a pulpily necrosed tooth. It could be mildly inflamed around the PDL due to an irreversible pulpitis where there is inflammation in the apical PDL, or it could be normal. So patients come to us with a certain level of preoperative pain. Now, I will propose to you the following, that if we do endodontic therapy, cleaning, shaping, irrigation, and disinfection right, from theoretical point of view, a patient should never have more pain post-operatively than they did preoperatively. Now, that's a pretty bold claim, but it basically lies on the simple fact that the root canal therapy, non-surgical root canal therapy, if it is confined to the inside of the root canal, so we're somewhere right here in the tooth, and we're able to prevent any extrusion of debris material as well as irrigation solutions, any of the caustic or pro-inflammatory irrigation solutions, or any mechanical over-instrumentation, we should have no different periapical condition post-operatively than preoperatively. Okay, so basically everything relies on 3 main factors. First factor being debris control, okay? Then the second factor would be irrigation control. And then the last one being instrument control. So you can kind of, break it down for these 3 things being debris, meaning that it's antigenic bacteria or biological burden. You could have irrigation control, which would be chemical burden to the periapical. And lastly, instrumentation control, which would be mechanical. Okay? So anytime you insult the periapical area of a tooth with any of these 3 type of injuries, biological, chemical, or mechanical, patients are going to have pain. There might be a biological problem here already due to a necrotic pulp, and that can get exacerbated if we are going to push debris out apically. So I'm going to obviously get into this concept in a very, very simple manner. I'm going to certainly create more content that is more, more scientific and robust in terms of the explanation of what happens down here that causes the pain. But for now, let's just keep it at a very macro structure and explain the process. So for biological component, how not to push debris out the apex, that's going to be a function of our instrumentation protocol. Any of this pumping motion of going up and down, any of this excessive reciprocation or too many strokes inside the tooth can generate a lot of debris, and that could cause a problem. Doing step back versus crown down has also been shown to create more debris that could get pushed out through this piston effect. With the chemical material, obviously during irrigation, you can end up getting some of this caustic irrigant out. Using side-vented needles, a little bit further from the apex, making sure that you don't jam the needle down, and you always have a loose needle, so it means thinner gauge needles, and having constant motion in the canal will help reduce the extrusion of the chemical. Also, perhaps as opposed to using full strength sodium hypochlorite, maybe reducing the concentration to anywhere in the 2 to 3% level could also potentially help. Additionally, adding negative pressure instead of just merely using positive pressure is also another way that you could reduce the extrusion of the chemicals out the end of the tooth. And then lastly, for mechanical instrumentation, keeping the working length faithfully and accurately, establishing it at whatever point you're doing during your crown down, and then staying faithful to it by having reproducible reference points that are going to allow you to make sure that you are measuring the length up to the working length that you've determined, and not go past through it 1 millimeter or half a millimeter routinely. All of these points are going to help reduce the biological, chemical, and the mechanical burden that comes out the end of the root. So I wanted to just give you this overview. There is a whole world of information about the basic mechanisms of this insult and how periapical lesions and post-op pain, or what's called a post-operative flare-up, which is basically what I'm talking about. A flare-up is anytime a patient has post-operative pain that's above and beyond their preoperative pain that is excessive. And that could be very painful to some patients, where they would basically put this on a scale of 0 to 10, say that their pain is 8 or 9, or even 10, as some people would say. So the incidence of this event of a post-operative flare-up is actually fairly rare, and it is in the order of 2 to about 5%, according to different investigators. Walton on the lower side and you on the larger side have shown that there is postoperative flare-ups that can occur, and the flare-ups definition obviously is being pain that is above and beyond, not just a little bit more pain than the preoperative pain, but significantly more pain and possibly swelling than their pre-op state. Now, studies have also shown that this postoperative pain is also associated with necrotic teeth, that are patients that have symptoms preoperatively are also more higher chance of getting postoperative pain, as well as the, according to Turabinejad, for example, they found that patients that have a history of allergies would have a higher incidence of pain as well. And this does make sense because a lot of the postoperative pain and flare-up is really a function of the immune system and its interaction in this periapical area. And different people, depending on your immune response, are going to respond differently to the antigens that are being introduced to the area. Of course, we know that the biological burden is primarily driven by the bacteria and also the antigens from the bacteria. For example, the LPS, or lipopolysaccharide, is a big time inducer of immune response because it's highly antigenic. And so in some cases, if you have a higher concentration of gram-negative anaerobic bacteria in the periapical area in a necrotic tooth, if that mix of bacteria contains more LPS, you're going to have more post-op pain postoperatively if you push any of that material out. So our best bet is really to employ techniques and materials that help and concentrate on our length control so that we don't push debris out, rather than try to manage it afterwards. Now, also, so what do we do afterwards if your patients have pain? It's always a good idea to give your patients a understanding that some post-op pain is possible after root canal therapy, and that it could be anywhere from mostly mild to moderate, and then rarely it could be severe. As I mentioned, the percentage is really low. So it's been shown that giving patients prophylactic antibiotics preoperatively does not, and I repeat, does not help reduce the incidence of post-op pain and flare-ups. So it's very important not to give every patient that you see that has a necrotic tooth antibiotics. As you know, I am very much adamantly against the use of antibiotics. So antibiotics are not a good indication for patients just to control post-op pain. Now, if there is a flare-up, and if you're in a 2 to 5%, some studies show that at that point, it does help resolve the symptoms a little bit quicker. But since I mentioned that the incidence is only 2 to 5%, it makes no sense to give 100% of patients antibiotics only so that you can, help address some of the 2 to 5% of people that have post-op flare-ups. So keep that in mind. Now, in terms of what is good for pain control postoperatively, I prefer to use a non-steroidal anti-inflammatory and combine that with a acetaminophen. Now, the idea there is that 400 to 600 milligrams of ibuprofen, which is an NSAID, is going to work locally in the site here, right at the site of inflammation at the apical area, by trying to, by blocking the cyclooxygenase kind of cascade and reduce the production of prostaglandins that are activating the pain in the area, as well as the use of Tylenol simultaneously through a different mechanism working in the brain to also reduce the perception of pain. So this is by combining ibuprofen with acetaminophen, you're getting a combined effect that helps reduce patient discomfort. The maximum dose is, of course, very important to keep in mind. No more than 200 milligrams of ibuprofen on a daily basis, and no more usually than 2 grams of acetaminophen. So somewhere in the order of 400 to 600 milligrams of ibuprofen and 325 milligram of acetaminophen every 4 to 6 hours for the patient will help reduce the pain. The indication for narcotics are few and far in between. It's a really good idea not to prescribe narcotics to patients. The over-prescription of narcotics have caused a major problem here in the U.S., and I'm sure it's the same elsewhere around the world as well. So if you do, however, need patients to have some relief at nighttime where a narcotic would probably be helpful, I personally prescribe Vicodin, which is a little bit of hydrocodone, with acetaminophen, and I tell them to take 1 or 2 ibuprofen along with it. So that basically, you're getting the ibuprofen or NSAID cascade, you're getting the Tylenol cascade, as well as the mu receptors blockage and so on through the narcotic cascade. So you're kind of getting it from 3 different angles, and it's been shown that the combining things, as long as they're not opposite to each other, combining different mechanisms that achieve the same end seems to have a synergistic effect. All right, so I can get into a lot of detail in this area of apical pathology and physiology, as well as the microbiology of the pulp, and I promise that I will in future videos. I do have significant plans of creating more kind of academic and more of an kind of videos that will explain to you some of the basic concepts of pulpal pathology, as well as pulpal microbiology and the mechanisms of disease in this area. So stay tuned. Those are all going to come over the next couple of years, as I'm going to produce a lot of videos for you guys, since you've all been so kind to give me a lot of good feedback that these things are helping you achieve great results, both from an understanding point of view as well as a clinical point of view. So as you saw, some common sense and possible instrumentation techniques and protocols, an understanding of the concept of working length, and then using time-proven protocols and techniques for managing debris, safe irrigation, are all going to go a long way to help reduce postoperative pain. When patients do have postoperative pain, there are techniques that can help reduce those discomfort, and we discussed all of those things. And I hope the combination of these tips and tricks and a foundational understanding of what causes postoperative pain in your patients can help you provide safer and more comfortable endodontic therapy, because remember, at the end of the day, our goal is to save more teeth. For Real Dendo, I'm Ali Nasseh, and I'll see you in the next video.